Welcome to Smart Village Movement's Partner Chat. We are in conversation with Apollo Hospitals Telehealth Unit, Chief Business Officer Prem Anand, and Mr. TamilMaran, our National Program Implementation and Program Development Director. Thank you for joining us today, Prem and TamilMaran. SVM's goal with this interview series is to identify, showcase, and support innovative business models that can be replicated across rural India and other developing countries. Today, we welcome our guests from Apollo Telehealth Unit who have partnered with us in Meghalaya to help solve the challenge of limited healthcare in rural areas by providing last-mile access. So Apollo Hospitals really needs no introduction. It is South Asia's leading private healthcare provider and has a robust presence across the healthcare ecosystem, with services that have touched millions of lives. In collaboration with the government of Meghalaya and Smart Village Movement, Apollo Telehealth has built 5 digital dispensaries in the state, combining a brick-and-mortar experience with cutting-edge tech solutions for last-mile access. This pilot project is aimed to provide quality services for doctor consultation, diagnostic services, and medicines in collaboration with the government. So, Prem, maybe if I can ask you this, a few years ago, I believe it was 2012, Apollo was recognized as one of the winners of the G20 Challenge on Inclusive Business Innovation. This was because Apollo created innovative, scalable, and commercially viable ways of working with low-income people in developing countries. Can you please tell us a little bit about Apollo's journey to serve in rural areas in India since then?
Thank you, and I'll take a minute to thank you all for inviting us today. It's very nice of you, and it's been a great learning experience in the last few years of putting up the Meghalaya Digital Dispensaries program managed by SVM, and we are glad that we were part of it and we got to work together. So coming back to your question, see, for Apollo, the community engagement work is as old as we started in 2000. It began with our chairman, Dr. Pratap C. Reddy, who returned back from the US in the early 80s. And he's also the founder and one of the first private sector investor in healthcare in the country. And post which a lot of privatization in healthcare did happen. So he wanted, post 1983 was when Apollo was started in India. By 2000, we were reasonably a large healthcare service provider in the country. And he hails from a small village in the state of Andhra Pradesh in India. Mm-hmm. And it's called Aragonda. And it's in a district called Chittoor. And he wanted to give back to his village. So that's how this whole community engagement started for us. And he wanted to do it from birth till the end. So everybody, it's about close to about 120,000. That's about 0.12 million people in the surrounding areas of villages who were enabled with technology enabled. That was also the first telehealth program in the country. It was inaugurated by the erstwhile president of the US, Mr. Bill Clinton. So he inaugurated the first satellite-connected telehealth program in the country. From there and now, it's been a long journey for us. And we're very happy to tell you that only in the remote healthcare division, which works in Meghalaya, we have touched or we have provided services to over 1.3 million people who are in remote cutoff locations. And our clinical interactions would be over and about, it was 10.3 million. I stand to correct. And we had about 20.8 million clinical interactions. And by any parlance, this is reasonably a good milestone, which has been motivating us to, do this work seriously. And why we are in this space is like, until a decade ago, the challenge was, how do you do this? I'd always told this in the past. Today also I went in another program engagement with another agency. They were saying, the whole country has only about 9 lakh. That's about 0.9 million doctors and how do we take it out and all that. These numbers keep coming up. But the fact of the matter is, until earlier, the only way out was to get more medical doctors to pass out of our medical universities, get more paramedical team enabled on ground. And even that, there's a lot of brain drain which happens in this part of the world. And it's how much of a medical colleges you build, they will get trained here and they will move out, and you can't stop that, right? So there are alternatives required, and that never evolved. And that's where, this technology-enabled remote healthcare services has made a huge difference. And there is hope. And for people like us, it's really accelerating to, work in this space and see every day, when we see across our projects, people, when you see a life saved. Like this week in Tripura, we had 2 geriatric patients, one with cardiac condition, other with hypertensive, low blood pressure situation, 82, 81. I can't imagine in those remote areas if they would have ever got stabilized if not for our tele-emergency services and so on. So that's been our revolution so far. And as an organization, Apollo is very committed to this at every level. At the board level, we have at least large entities of 23 independent organizations. People know us as an hospital entity. We also have a large pharmacy network. We have a diagnostics network. We have a clinics network. We are now having the largest presence through our Apollo 24/7 on the retail space on an app, a teleclinic app, and so on and so forth. Every single organization is committed that, we have to get this inclusive system in place to cover the people who have not been covered in the past.
Correct. And, we've noticed that this is really SVM's foundational thing, right? There's such a huge rural-urban gap that people, even talented individuals from the villages, will choose to migrate either to the metro cities or elsewhere. Yes, we do have government medical students coming, to do their residency in the villages, but when they finish, while they're still junior, they tend to leave, which is why we don't get good doctors and specialists in the rural areas. So our hope is that with Smart Village Movement's integrative treatment of building up the rural areas, we bring in education and livelihood too, so people will choose to stay in area that's actually conducive to raising a family for them as well. So, that's our 10-year plan. Hopefully we choose to have doctors and specialists come in and actually stay where the clinics are, so you don't have this issue of not having the specialists. But in 2021, we actually launched our first Apollo clinics in Meghalaya, and we've built to 5 Apollo telehealth clinics now. Our testimonials from the field have shown this was actually a very great benefit to the villagers because they had to travel to Shillong for all their services before, and it has saved them significant amounts of time and money in seeking healthcare. So can you all tell us a little bit about the experience of customizing Apollo's business model with SVM to this specific rural market in Meghalaya? And I'll let our team actually speak to that too after Prem and Maran, you can give in your inputs.
So, see, this partnership with SVM is very unique in the country. I would call SVM as a catalyst, not even an integrator. A catalyst is an important role. And the structure in which SVM is designed, not for profit, professionals coming in and program managers. And that's an area for sure many of them would agree to this. Okay. And that's how many of the countries develop their, logistics infrastructure, develop their kind of common, much needed nation building entities like the airports, the shipping yards, the roads, and so on and so forth. But when it comes to service delivery, PPP didn't take shape. Public-private partnership didn't take. And we were a few of the first runners to have created PPP in healthcare. There should be PPP in school education. There should be PPP in agriculture. Correct. And things like that. So when it comes to healthcare, what is the challenge? The challenge is not only about not having services available at the grassroots level, or like, there are guidelines, everybody should be familiar with healthcare for all, the Alma-Ata declaration for the globe, and having one doctor for every 1,000 patients and all of that. Now, even if we had achieved that to put, the infra and the clinicians on ground, I think it would have still been a challenge. Because unlike any other service, healthcare is not something to celebrate about, right? You can't say that, I did 100 patients and it's a great news. No, it's not a great news. You had 100 sick patients and it's nothing to celebrate about it, right? And we want if everybody has good health, then there's no work for all of us put together. So it's a very ethical and a dilemma issue here. What is happening in the grassroots level is lack of awareness. Okay. And India is country within countries. Every region, every state, and even I would say every district, and sometimes even some of the villages within a district or a block has their own belief systems. In my journey of 18 years in the community health space, I've met people in grassroots level who said, don't click a picture. 5 years of my life will be lost. We can't take a picture there. I've entered villages in this country where they say, remove your footwear outside at this point and walk without a slipper, because we consider the land as, the Almighty God and things like that. There's so many belief systems. Going to a medical doctor is considered as a bad omen in some of the villages. So I can narrate a lot of my, journey stories like this. We don't have health-seeking behavior. Like, for example, someone like me, I'm giving myself as an example. When my son was born, I was able to detect at the age of 2.5 or 3 years that he's got a vision problem. Mm-hmm. He can't speak well. Okay, he's active. And no normal person, even if they were educated, would miss this. Many of the congenital cataract cases for newborn babies are missed out in this country. I'm just giving eye care as an example. We realized, because not by virtue of training alone, by virtue of engaging with the communities, I realized that, my son has got a problem. We took him to the doctor and he's been wearing spectacles ever since he was 3. And I'm someone who's been engaged in the community ophthalmology space since 1998. Mm-hmm. And I can tell you that nothing less than 20-30 million people would have got benefited through the work we have done. And my son had to wear specs was a heartening thing for me. But then I'm thankful to God that I was involved in this kind of work. So I learned it. Mm-hmm. So health-seeking behavior is not there. And since health-seeking behavior is not there, even if you had set it up, you may not be able to get them to use the service, and they will only come when pain gets manifested. So in people who are well educated, you will definitely go for an eye checkup every year, even if you are feeling all right. You will do your blood samples for various NCDs and other ailments. Mm-hmm. And you would try to take care. Now, this is a culture. And for people to either spend money or even when it's given for free to come and do this preventive health checks, it's a cultural change. We have a long journey to go in this space. And in Meghalaya, in these 5 villages, I'm very happy that, all of us coming together, we have started the social health education program, and it's yielding a lot of results. The
social aspects in India, the cultural wash that we have all come from, they all change from state to state too. And Smart Village Movement has made a small initiative called the Prevent PPHM, which I'm going to give the floor to Alvarine and Tulinam to speak a little bit about it, because it's such a great point that you've made, that health-seeking behavior is not primary in the minds of Indian, especially in the rural communities. It's kind of like the Maslow's hierarchy of needs, right? Unless they have food on their table and they're satisfied in other aspects of their life, if something ain't broke, they're not going to fix it. So they don't go to the doctor to get their checkups and get their blood work done, or even find out from a pediatric point of view what their children might need in the future. So Alvarine and Tulanam, could you take a couple of minutes to talk about the PPHM model? And I know Tulanam has had some great news recently, but let's talk about what PPHM and how we can work that into Apollo's vision as well of bringing healthcare to everyone in the rural areas.
Everyone for being here. I think this engagement with the doyens of the healthcare space in the region is a very encouraging value creation process for us, because I think very evidently through these initiatives, we have seen how much it has unleashed that aspiration, both from an institutional point of view or at the community, and to put commerce, community and compassion together, I think is really something that we find it fulfilling, and to be involved with the Apollo Hospitals is really, a very complimentary affair. And yes, I think just taking from the, the highlights of Mr. Prem Anand about how, these arrangements will probably derive long-term dividends in the healthcare space, from disease management to disease prevention, and that would definitely give good ROIs for public healthcare systems, for private enterprises, and most importantly, to really improve the healthcare scenario in the country. And I think the role of agencies like Apollo Hospitals, who bring in both curative and preventive aspects here, become very effective functional means to open innovation, whereby I think designing some processes to leverage technology, leverage healthcare diagnostic clinical capabilities with I think artificial intelligence, designing some processes to leverage technology, leverage healthcare diagnostic clinical capabilities with I think artificial intelligence really help in driving the the unique challenges and the complexities of the world that we're living in today. And to be able to contextualize that to the peculiar circumstances of different regions, I think is something that is very core. And yes, this positive public healthcare management model is an outcome and a continuation of the state health policy, which of Meghalaya, which is envisioned towards a shift from the paradigm of disease management to disease prevention. I think with all these factors and components in place, the results, the outcomes would definitely really help in driving the the unique challenges and the complexities of the world that we're living in today. And to be able to contextualize that to the encourages people to really consider healthcare, as an agenda that needs to be democratized, decentralized, and popularized. And I'm very glad to be having the expertise from the administration, the government leadership, and of course the healthcare enterprise. So I think that's about it. But yes, Alvarine, you can definitely weigh into value add the conversation on ground. Thank you.
Thank you.
Thanks. Yeah, thanks, Tulanam. So from what Prem said, about the health-seeking behavior. I think PPHM is also the positive public healthcare management project that is being promoted by the government of Meghalaya is also a way to, improve health-seeking behavior, which lacks actually in rural areas. Maybe it may not be that much in the urban areas, but yes, definitely in rural areas, that's an issue. And I guess if we are talking about customizing models to make, these approaches work, community mobilization is one of the main aspect where, PPHM has been focusing on, because if people do not realize that health is their priority, how do you make them understand that? How do you make them understand that health is not something that can be borrowed from someone, but it's something that it's a responsibility that you have to take on your own? So, and I think SVM as an organization with its innovative approach has been able to, experiment on ground. We have worked with existing networks of the government, such as the self-help groups, where you have women from every household in the village, trying to make them understand the importance of a proactive health checkup, and then eventually mobilizing them to come forward for these health checkups. And I think Apollo also, in its own way, when we've started the social health education program, that is also another way of raising behavior among women about how they should take prioritize their health, understand about the health issues that they have, and come forward, see a doctor, and not wait until that it's too late to get the conditions that they are in corrected. So that's about it, about positive preventive healthcare initiative.
In April this year, actually, I had the good fortune of visiting one of the rural healthcare outreach camps. I think it was for awareness campaign with Alvarine, who is our lead healthcare fellow. And I know that just talking to the villagers there, I can see that they feel so much satisfaction that something like this is now coming closer to their village itself, right, Alvarine? Can you, apart from the challenges of the operations, can you tell us a little bit about, being on the field and talking to the villagers themselves? What are some of the benefits and the, I guess, how do they feel about Apollo's interventions, in their remote areas? And what kind of feedback do you get from them?
Yeah. So the immediate response that you get from people when you talk about Apollo is that they for a villager living in an absolutely rural area, they don't get to see clinics as good looking as Apollo's. The aesthetics of it is something, it's something that would and help them aspire or feel like going to a clinic where they can meet a doctor and even get all the medicines that they would want, because that is something that they cannot get when they go to a government health facility. That is the main complaint that we hear most of the time. But I think the other response that we get from the villagers is that the treatment that they get from Apollo are effective, and that's the reason why they keep coming back to the clinic again and again. And the other benefit is that they see is the cost, which is reduced. They don't have to travel all the way to Shillong or to private clinic, which is located a little further, where they have to spend some amount, but they can just walk in to this clinic, which is located quite close to their village, and access quality healthcare at an affordable price.
Great, thank you so much. Telemedicine and artificial intelligence in the healthcare realm are helping to make quality accessible to more and more underserved people than ever before. I'm sure that in spite of the operational challenges, it brings Apollo great fulfillment to serve all these communities. Prem, can you share some new innovations and developments in healthcare outreach and distribution from the technology point of view that Apollo is most excited about?
Yeah, so I'll speak about the AI. On the telemedicine part, I think Maran, who's been on ground, he's the man who drives day in and day out. I'll have him to speak. So I'll tell you how we are structured behind, and that's why it's been what we did now. It was even possible. So we have our own in-house independent entity for technology arm. So we are a full-fledged tech company which has been working on building the telemedicine electronic medical record system and the associated components of quality management, laboratory information systems, pharmacy modules. You had also touched upon the subject of building capacity on ground. Mm-hmm. So learning management system is an integral part, because that's a very essential part in terms of, if you don't challenge the resources on the ground clinically, they feel outdated. So they start seeking to move out. Whereas our entire intention of building health system strengthening can only happen if we give that, challenging environment for them to understand holistically the length and breadth of, clinical aspects of, providing care services in the space. So this is an integrated model which we have built, and it's an evolving model. And this is the basic, we call it as MedX. It was earlier called, this platform was called MediIntegra. Now it's moving on to MedX. And this platform, from being a basic teleconsult platform, has evolved to develop modules for tele-ICU, tele-emergencies, which are also IM services, which we've been rolling out with various state governments and remote locations where, emergency care is not available. Over and above that, we have built a lot of analytics, like the transparent dashboard which we have given for this program is one on that direction that, we become completely accountable. You know what time our center goes live, how many centers are live, how many doctors went, gave these services, what kind of medicines got dispensed, without compromising on patient privacy, all the required data. And tomorrow, any state wants to analyze health indicators or prevalence rate of diseases and things like that, this becomes a very effective source. So we conceptualized this at least decades back. And on the AI front, what we've been doing is we've applied that to some of these sub-practices, like radiology. We have a full-fledged independent teleradiology enterprise, a company. And they're working on AI for analyzing, screening, first level of diagnosis, image reading. And we have also built, and we are working on ophthalmology, the fundus image grading system, which can diagnose conditions such as diabetic retinopathy, hypertensive retinopathy, and so on and so forth, based on image grading through artificial intelligence. And there are a lot more other applications in terms of AI being introduced into, if you look at clinical reports, particularly in the investigation and diagnosis part, a lot of these investigation reports, though it's handed over to the patient, they really don't understand what it means in literal terms. We are moving on that level of AI to be built for people to understand clinical terms in simple parlance, so that they know what's happening to them. You capacitate, you build, you empower patients to know what's happening to them. So there's a lot of such work happening. But one pointer in the AI spaces, in India at least, and I believe as long as we drive this space, automating clinical consultations, though it is possible, like clinical decision support systems and so on and so forth, though we are building and we have it, we will not deploy it immediately. I don't see this happening in next half a decade or so either, because that requires a lot of time testing and validation. So that's how much in terms of the technology piece we've been working on. And it's an evolving space, and it's evolving very rapidly. Yeah. So Maran, do you want to speak about the telemedicine on ground?
Yes, sir. Hi, Anand. Good morning, and Tulena Malvarin, good evening. So good to see you all. See, healthcare-enabled technology there in the country more than 2 decades, I think, as far as my knowledge. Whereas COVID has given a wake-up call to the people that, yes, telemedicine, people have started accepting, including the doctors who used to do the regular consultation in the hospital. So bringing such kind of a new initiative into the rural is always challenged, whether it is pre-COVID or post-COVID also. But we are very confident that what we learned, that people expect acceptance, it's very much important actually. So people are accepted the technology, that the mobile phone, what we were used earlier and what we are using it, people are accepted the technology. So what the A village, if you go, the people mentality will be something different. The B village, if you go, the people mentality is something different. End of the day, the healthcare need is there. So for that, what we have done it actually, community intervention. Community intervention in the sense that it's not that going there doing outreach activity. We need to make the people to understand, and they should believe, yes, there is some technology have come, they should start using it actually. So that is how we have done it, especially in Meghalaya. And we are, because every village and every the part of the states in the country culturally is varied, and then people mentality also is different actually. The rural people, there is wherever we go and meet new people, rural people always expect the doctor have to come and touch. Yes, it was there. Why? Because they believe in it that if the doctor is putting the hand on me, that I'll get cured. Because that confidence. The confidence we have given through technology-enabled healthcare and bringing to them center, the doctor, the doctor, how he is interacting, and we have to understand the actual need of the patient and giving the medication and then the laboratory stuff. That's why we are calling it as a digital dispensary. So the loophole will get over. So after the doctor consultation, medicine and laboratory, we don't just leave them after that consultation. We do follow up with them. Continuum of care. So that is also one of the most important aspects that people are started believing that yes, the telemedicine will be one of the useful thing for them, and through that we can able to reach out many people. And one of the good thing is that once you make 10 or 15 people satisfied, word of mouth, that awareness will spread across in the village. That is also one of the success for us to reach out to more people through technology-enabled healthcare system in the country.
Thank you. Thank you very much, Maran. Yes, for sure. We are at the beginning of a learning curve, right, for rural communities. And everyone in India has a smartphone in their hand now. So it's only a matter of time before all these new innovations are going to become like a usual practice for them. So, SVM as a facilitator, a catalyst, a system integrator, we hope to bring more and more pilots like Apollo's on the ground. And what we aim to do is help you refine your business model to the rural context. So in that spirit, how can we provide more value as a knowledge partner and a facilitator as you scale pilots throughout the state and even beyond in India?
Okay. So do you want to address?
No, take that.
Sorry, sir?
Maran, you can go ahead because you are in charge of implementing those programs, right?
Yeah.
So please.
For this kind of a telemedicine health intervention program, identifying the right place where there is a need actually, that is one of the success of the program actually. If you look at the place what we have identified, there is a need, and there is also, if you look at nearby our center, you can't be able to see the households. So we have to do that need assessment, that what is the need of that particular place and how the people are accessing the healthcare. So that will help you to understand. This is not only for that, the households. We will have to look for the schools and then the colleges. And these are the key aspects. And what is the government facility in that particular area, how it is going to be useful. Because the digital dispensary, we have some limitation. That there are some people who may require further intervention like surgery and then other aspects actually. We may have to refer them. So this ground assessment is very much important. And, that will get vary from one village to another village, one state to other village. So accordingly, we can allow to see that how we are going to execute in the particular area. So
I also want to add a point there, Anna.
Mm-hmm.
Actually, Ayushman Bharat, the present union government is making phenomenal strides in it. It's considered to be one of the largest health insurance scheme even globally. I remember the kind of budgeting which has been done in the union budget. It's very huge. I am not able to recollect quickly, but I'll tell you how it all started. Hospitalization is considered to be a huge out-of-pocket expenditure for people who are living below the poverty line, or even for average people. The poverty line number here is less than $1 or $2 today, and people are living out of $1 a day kind of income. So the government came out, and current model is that Indian money value wise, it's 0.5 million coverage for an entire family, and they have included very high-end surgeries also. But the reason there was a large event of celebrating, I think, Ayushman Bharat 2 or 3 years implementation stage, there are close to about 150,000 private sector and government clinical establishments which have enrolled with the government to deliver the services. Now, the challenge here is, though the government has the budget, the processes which revolves around it. Somebody should be able to seamlessly walk into any of these health facilities, whether it is government or private, give them the unique ID or code or enrollment card or health card, whatever, and be able to get that service seamlessly. That is what government is trying to streamline and do that. So budgets, as far as India is concerned, is not technically a problem. Like Maran said, OPD services, again, all the primary health centers and the community health centers of the government are getting upgraded into an health and wellness center. All what we are providing, the government has studied various models, including our model to a large extent. They're trying to enable it through telemedicine platform, through provisioning medical doctors, so on and so forth. But as Maran said, the delivery channel is little varied across, even in the private sector. So coming to whether this will become a retail, whether people will directly adopt and they will be able to just with a click of a app on their phone, whether they are able to connect to an Apollo or to any other private system or to any government health facilities, will it going to happen? I think it will take little time. A generation has to move on. The new generation which is coming in is more oriented to digital adoption. It will happen. But where the challenge is going to be is, unlike any other service, the most celebrated model globally is the old Uber, the taxi integration model, where people quickly adopted. There was a logistics, particularly in Asian countries where with large population, and it was expensive and things like that. But there the transaction is very straightforward. You start from A point and you want to go travel to the B point, and you have a choice of vehicles to pick up, and the time, it's fairly well defined. But in healthcare, every patient is unique, and there are associated services along with it. Diagnostics has to come, radiology services has to come, and dispensing of medicines has to come. And once you are identified for an interventional service or a procedure, a referral mechanism has to happen seamlessly. And until all this gets integrated seamlessly, adoption into a B2C will see some challenges, but it will evolve. It may not happen at the rapid pace at which people are expecting. There's huge investment, PE funding going into promoting so many R&D based, healthcare, digital entrepreneurs and companies. It'll all consolidate, just like what happened in telecom. When telecom opened up in India, when teledensity was in 97, I remember we did a research based on which we moved into digital, building up our own networks into rural for many services. Teledensity in India was 26 or 28%. Today we are over 95% upwards. And India has adopted well. I mean, I can tell you, I have relatives who don't understand the menu in English, but they identify icons and they're using, elderly people using the mobile phone seamlessly. This adoption will take some time, but it will happen. But putting the business model around it is going to be slightly challenging.
That's true. And, that's why we hope that Smart Village movement, along with UC Berkeley Haas, and their business model refinement, can bring and facilitate more sustainable business models for all our partners. This is going to be our last question for the day, Prem and TamilMaran. As you know, you mentioned the dashboard, right, Prem, the dashboard that Apollo has in the clinics. And I have to say that as somebody who is hoping to translate data and data points into effective communication, it was a lifesaver. You're one of the partners that has the most refined forms of reporting, which is how we can then have evaluation reports and impact reports easily made through UC Berkeley. So thank you very much for that. And this is a classic example of open innovation, according to us. It's a founding principle for Smart Village movement. And Apollo Hospital has made their information totally transparent, that anybody can use this information and take and refine their own business models. So open innovation is the concept that has been introduced and refined at UC Berkeley, the Haas School of Business, our knowledge and research partner. In this spirit of collaboration and co-innovation, we seek to bring global best practices together on our platform, and we want to help solve the challenges that face all of humanity. So what is Apollo's broader vision that drives the organization to excellence? And what advice would you share with other smaller startups and companies that are not as evolved as Apollo, that seek to address rural challenges on our platform, whether it's healthcare or even agriculture or education, for example?
So I would put it this way. It's a very important question. The reason is, for someone like me who's been involved in using technology for rural development, I have come across, I'll tell you, I mean, I can't name this company. The first workshop for putting up a remote diagnostic devices, where I was involved, was 97 at IIT Chennai. And it was like taking innovations from lab to land. Lab to land. is an important aspect. Many times what I find, this new age, the new generation X kind of people who are full of energy, full of innovation, full of aspiration. Secondary data study, data point analysis is one aspect, but when it comes to specifically to healthcare, talk about healthcare and about the general other line of business too, is you need to test it. I can give you ample examples. I'll give you one in agriculture, which I saw way back in the early 2000s as an example, is you may create best of best technology, but when you put it to use on the ground, you need to understand whether it's operationally fitting in, whether it is culturally, possible to do those kind of tests. Like, for example, my staff, they were doing in Himalayas. I'm just giving you an example. In the Himalayas, it's very cold, and we operate at 12,000 feet. They're putting the BP cup on top of the woolen sweater the lady was wearing. And this was going on for some time until a doctor figured out and said, I understand it's very cold, but you can't do the BP, evaluation this way. So if it is difficult for those people to wear the kind of clothes we wear here, then please ensure that you take the BP, you can cut off the video and ask her to, remove her clothes and do it properly and get me the parameter. And so why I'm giving you this example is when you design a new innovative technology, you have to consider all these things. It doesn't happen through a flow chart alone, which is put together in the urban localities of the world. Similarly, I'll share another thing which I learned. So when we got started way back into rural, using technology for rural development, agriculture also was one of the thematic area which I had an opportunity to work. Mm-hmm. So there was this situation in a certain village, and we had set up an information center, with homegrown technology. The bandwidth capability at that time was 75 kbps. You would laugh if I tell you that. We started this work down south, connecting a rural village to a district headquarters hub, and interconnecting the agricultural university and the animal husbandry government institution and so on and so forth. So this farmer had a problem. His coconut, the nut was not fruiting, mm-hmm. and it got a disease, and it's like turning brown and all kinds of things. So the solution which came from one of the professors was that you have to, take this mix. It's a combination of some bio fertilizer and stuff like that with some chemicals added. Go up on top, and you'll have to rub it against all the nuts on top of the tree, and you have to do this for some 100, 200 trees. At that point, this was one that I don't vividly remember the name of the disease, but I remember this incident. The farmer just looked at him in shock. He said, "Do you understand why I do?" And this is someone who's not even gone to probably an high school or even lesser. I'm talking way back in the late 90s. He said, if I have to do that, how much it costs me? How many people have to be involved? And finally, do you know what is the price I'll get for this nut?
Exactly. So, show me the money. That's where it eventually comes down to, right? Even though it may be a brilliant idea theoretically, it has to be commercially viable for a business to stay on ground and for a community to adopt certain technologies as well. You're absolutely right.
Thank you for joining us today, Prem and TamilMaran. We are delighted to learn so much about Apollo's vision and innovative practices in healthcare. Thank you to our wonderful audience for joining us today. This was the first of SVM's virtual partner chats, and we look forward to taking you through our next initiative over the next month with the STEM education initiative we have in the Northeast.